Good afternoon, everyone. We're going to get started. Feel free to come on up and have a seat after you get your lunch. Okay, so welcome to Books and Bagels. Books and Bagels is a program sponsored by the Graduate Student Association, Office of Graduate Studies, and now Student Affairs Center City. So we'd like to welcome you to our second Books and Bagels in Center City this year. And we have 5 very awesome speakers today, one group of 3. So they're going to be telling you a little bit about their research and what they do, and kind of give you a general overview of the kinds of things that they're working on as graduate students. So I'd like to introduce our moderator for today. We will have questions and answers at the end of the presentation once everyone has completed. There will be some time for discussion, question, and answer, so just keep your questions in mind. I'd like to introduce now Kathleen Turner, who is the Outreach and Liaison Librarian here.
Hello, everyone, and welcome to the Student Lounge in Ottoman. Most of you, I think, are students here, and we see you here all the time. But I'm really glad to have a chance to participate in this event. I think these are really exciting opportunities, both for the people presenting, to have a little chance to, talk to their peers, other students, people in other programs about the work that they're doing, and for the students who get a chance to see, well, what are the opportunities that I might have to go on and do research in my field? What are other people working on? And for me, honestly, it's absolutely wonderful to see the things that I might have seen at the very start of a project, of someone coming into the library saying, are there any articles out there on this? And then it goes on, and it turns into a presentation, and it turns into a dissertation, and it turns into professional presentations at conferences. And it's really fantastic to see that progress. So all of you, grab yourself some lunch, come on in and sit down. Right? So we've got 5 speakers doing 3 presentations. And as Seriki said, what we'll do is we'll hear each one of the speakers, their groups, and then have some time at the end for some questions and conversation. So let me introduce you to our first speaker, Carol Ann Blank. She's a doctoral candidate in the Creative Arts and Therapies Department. And her area of interest is in understanding the music therapist's decision-making process when working with a parent and child dyad in the individual music therapy setting. Carol Ann works for Music Together, an early childhood music and movement company, as a program developer and special needs coordinator, and is mother to 2 amazing young children. And Carol Ann and Amy and I have just been comparing notes about working in parenthood and the fun adventure that can be. Carol's presentation is on the role of family music therapy to support the development of children with special needs and parent self-efficacy. Her review of the literature in music therapy, family therapy, and early childhood development explores theories underpinning the role of group and individual experiences of music with families to address both the developmental needs of young children with disabilities and parental self-efficacy. So as Carol gets started again, if all of you in the back can help yourself to lunch and come find yourself a seat, we'll listen to Carol's presentation.
I especially encourage you to come move as forward as you can there'll be video, and you won't be able to hear it as well in the back. So hi, everybody, and thank you for the opportunity to talk with you today. So this is what we're going to be talking about. I'll define a little bit about what family music therapy is. You'll meet Matthew and Mom and their quest for a normalizing experience. You'll see what that means in a minute. And John and his mom, and illustrating something that we call communicative musicality in music therapy. So, what you might not know, and what I certainly didn't know when I headed into this area of research, is that there is a huge negative impact on raising a child with a special needs on their family. Some of the research that I've been reading has said that families who are raising a child with a complex medical need, they have much higher rates of divorce, much higher rates of poverty, and much higher rates of parental stress and God forbid there are siblings in the family system too. That whole system can be very disrupted. And while there are services available, services sometimes don't always get matched to the families in ways that are always helpful. We have seen in the music therapy literature the positive impact of music therapy on the development of young children with special needs. There's also information, more and more of it coming out about the positive impact of music therapy on families. And a lot of this happens not in the States, but in Australia. This is a very heavy body of knowledge coming out, both in qualitative and quantitative research methodologies coming from the Australians. And of course, there is an intersection between family music therapy and family therapy. And this is where the literature really, I found, has been very thin. The family music therapists aren't necessarily aware of what the music therapists are doing, and the reverse is also true. So part of what I'm hopeful to accomplish through my research is sort of expanding those two layers of overlap so that the lessons learned in one area can inform the work in other areas. And a couple of family therapy programs here just rocks the house, and I very much enjoy learning what I do, both from the couple of family therapy doctoral students and also being part of and also, I'll talk a little bit about some research that's in progress around the U.S. There's so much to talk about, so that part right now get as full of pieces of information. So these are the consequences. One in 5 households in the U.S. are raising a child with special health training. 1 in 5 households. So that on your block, if you're in single-family homes, that's at least 2 to 3 households are raising a child with a complex need. Families struggle to obtain or keep adequate health insurance. Their caregiver burdens, reduction or elimination of paid work hours, financial constraints. Insurance doesn't cover a lot of what a family needs, so out-of-pocket expenses often are subsume the family budget. And the levels of parent stress and employment choices and marital satisfaction are actually related to the child's diagnosis. So some of the research I've been reading says if you have a child with Down syndrome, the rates of divorce are less than if you have a child who's severely impacted with autism or severely impacted with some other complex medical needs. So it's quite a mix. So let's meet Matthew and his mom. Matthew has a congenital heart condition, and he is in Children's Hospital of Philadelphia. He is with his mom. In his music therapy session, I have permission to use this video, that will be uploaded. And I'd like you just to notice what you notice. He's a pretty sick kid, and he had recently recovered from a very traumatic illness while he was in the hospital. So he's not really a whole lot reactive, you know. He's a sick kid. But I want you to see what you can see, and then we'll chat about it in a second. Just for that. going to talk over this a little bit. He is being fed through a tube. He's traced, but he can't use his voice. He has tubes pretty much everywhere. The therapist is sitting in front of them. She has a guitar. She's down because she's on no contact. She's masked. She's playing her guitar with latex gloves on. She's telling Mom saying, dance, dance. All right, she's not masked. I thought that's what she was. Every time Mom positions him, she has to make sure that the wires and the cords are okay. It's not a normal experience for an 8-month-old. But being in a music class is, or music experience with Mom, is a normal experience for a child. He could very well be going to a Mommy and Me music class outside. Okay, so what did you notice?
Like maybe really fatigued.
Yeah. Mm-hmm. And you can see that by the fact that every so often his energy level just was so low. And he would look to Mom and that rapprochement, you know, that coming and going. He just told me, so what did you notice about Mom?
She does, trying to look frustrated.
Yeah. Yeah.
She's providing a lot of stimulation, like things in a hand, and then she's rocking a lot higher.
I think she was struggling, you know, like when the therapist was talking about the dancing for her son. I think it's trying to encourage that attachment happen, you know, to be together and know how to be together, how to hug him. And I think it might be a struggle for her, like how I'm going to hold him, hug him with all of the students around. And right, I think she was struggling with those, so she was doing all kinds of things to try to figure it out how to connect with her son.
Right. All of these things are very much at play for them. In one way, she wants him to wake up out of all of this. You know, let's raise the multimodal stimulation to jumpstart his sensory system into participating more. Later, about 20 minutes into the session, he's all over some bells and his drums. Things do really get cooking for him later on in the session. This is the very beginning, and things are not fun for him. So we talked a little bit about what the therapist was doing with the child, and just for the interest of time, I'm going to rattle off the points that I really want you to know. Otherwise, we would have a lovely discussion. So, music therapist is providing auditory and visual stimulation. She's also, with the mom, creating this inviting, welcoming container, this musical container, and also a visual container that allows for them to stop focusing on the wires and the beats and the poles and the bed and all this other stuff. Mom is providing all that multimodal stimulation, the physicality of it all. And Mom is communicating, albeit non-verbally in this clip, with how she's feeling and about herself, but also about her child at the same time. In order to understand how this child is really delayed, you can just look at the clinical picture, but you also should know musically what's happening for him and what should be happening for him. There are stages of music development, tonal and rhythm development, that I'm not sure we always know about. At this age, he's about 8 months old, but he should be holding certain instruments. This is the 4 to 6 month age range. Beginning purposeful responses to music. Getting excited about a particular song. He may have that, like to call it sort of that toddler scooch, you know, like your body sort of wiggles in the middle when you're sitting, that you're so happy that something is happening. That kind of stuff happens, and it's less reflexive than in infancy and more purposeful because the child is really beginning to develop an ability to create relationships from very early on. Unfortunately, this child is trained, so he can't use his voice. But if he were, he would be cooing or crying or in the same key as the music stimulant. We also should be hearing more tones from him, more vocalizations from him that are recognizable as singing, especially in the silences of after a song. If you hear a tone that's in the key of the song that you're hearing, you're realizing that's really what the child is doing, is communicating to you, saying, I want more of that, give that back, you took away something nice. So this is one of the things that is pretty explicit in the music therapy and early childhood music education literature. So then you have to look at the family therapy literature. So attachment-based family therapy comes from the idea that parents are responsible to provide a secure base from which the child can then grow. And the parents do this, for instance, by providing eye contact and holding and stroking and feeding and talking in that sing-songy way that we do with children. And that's actually a real thing. That's called parent ease. And children for whom their parents, for one reason or another, don't sing and speak in that way to their child at a very young age, actually have fewer words going into preschool. Depressed mothers have less of that communication with their children. So there are long, and these early disruptions to child and parent development actually, you can still see the effects of these when the child is as old as 4. Family music therapy is what we call a music therapy intervention that focuses on usually starting with one identified patient, but then engages the entire family system. What we notice from the literature, when we treat parent-child dyads, is that there are benefits not just to the child in terms of, especially premature infants, in terms of better oxygenation, better ability to feed, less crying behaviors, faster discharge 2 to 10 days earlier from the NICU. Those children who receive music therapy, but also the mothers have benefit too, with physiological, lowered stress hormones, and also on the qualitative end, increased feelings of confidence in caring for their newborn. But then the family music therapy, if you look at it as older children, they're perceived, these family music therapy groups are perceived really beneficial for families with children with disabilities, especially if typically developing siblings are involved, because it creates an even playing field for all of the members of the family and for multiple families. Being able to have a social and therapeutic experience that involves a whole, a subset of community provides us, again, a normalizing experience for families for whom this isn't necessarily an option. Music actually, because of the work of mirror neurons, music and self-regulation go hand in hand. Music activates many parts of the brain all at once, and self-regulation is that ability to monitor your own internal state of arousal. When you have music, when you engage in a music, either listening or music experience, you're allowing your brain to have that opportunity to kind of shift gears. And that helps you along with the presence of, along with mirror neurons, to be able to see and then replicate what's happening. There's a really great video that goes around where his dad, there are two kids, two babies on the floor in onesies. His dad is marching to some serious marching music, and he's, you know, being all kinds of dad-like and having fun, and then he stops. And then he marches again, and the kids are marching. I mean, they're laying down, they're not going anywhere, but the kids are marching. And then he stops, and so do they. And then he does it again, and they start wiggling their cute little bodies. And then he stops, and so do they. That's mirror neurons at work. You're seeing what you're doing, and you're able to replicate it. This is John. He's 23 months old. He has a variety of complex medical issues. The longest he had been out of the hospital since the time he was born was 3 months. I started seeing him at about 18 months, where he's now at 23 months. And he, in addition to having all of his issues, he was also diagnosed as at risk for autism. We're looking at communication in this experience. So again, Mom just says we're having a difficulty with transitioning right now. It seems the audio and video are not the same. Sorry. Here. He's in the same key. He's on the dominant, the fifth scale tone above. He has a big surgical scar, so we're making sure he's comfortable with that. I pull out a drum. I ask him if he wants the mallet, and I ask him to pick it from a big array of instruments, a big bag. He's got to find it. He finds it. Way interested in technology. Tested me. I should have put it down, please. He referenced his mom. That's myself. And what did she do? All right, you're fine. Let's move along. I'm also pretty intentional with my positioning. I'm not in there. This is about them. I'm back. And I'm providing, basically, again, that container for them to work within. He started alternating his hands, so we did too. I'm getting the sense that perhaps somebody else should have a mallet too. So I offer a mallet, and Mom takes it. See how much gaze he's giving to her? I want the mallet, but Mom is establishing her boundary. I want the mallet too. We're going to do this together. And he doesn't lose his mind. Okay. Get the point? Okay. So, yeah. So, do you have any questions about that video or any other statements? At this point, we didn't know, but she had just gotten the diagnosis the day before. Pretty functional, but he was delayed in a whole lot of areas. It was that whole transition. You missed the first 20 minutes of the session where he basically cried his way through the whole opening. It was pretty horrendous. So that rigidity, always needing things done at the same time, these are the things that those target areas for him. Not unusual for a kid who's sent off to the first year in the hospital being done to rather than with. So my education process and my clinical process is a lot of this. I'm exposed to new ideas, I experiment with the ideas in my practice, I create new ideas, and I just continue in that sort of iterative cycle. So I do want to understand more about what was going through my mind as a music therapist and what goes through other music therapists' minds who are trying to figure out what to do with these kids and their parents so that they have a good outcome and are able to prepare some of the early disruptions to their families. So, thanks very much.
Again, we'll have more time for questions and conversation at the end. And I think any more of that we would need to be passing some tissues around the room too. Right. While we switch out equipment, let me introduce our next speaker. Those of you who are in the back, if you want to get some lunch, come sit down and join us. Please do. Our next speakers, we actually have a group, Tomi and Tosin, Seriki, and Idris from the School of Public Health. They're students in the master's program with a concentration.
Is one of you okay with switching the slides while they one of you can switch the slides? Okay. I'll put this straight here in front of the table.
And with that experience, they were able to formulate a community-based master's thesis project. This is what the School of Public Health students do as the culmination of their education here. The CBOS project, right? Okay. They focused on advancing mobile health in rural Gambia by improving dental health practices using SMS text messaging, as well as enhancing vaccine inventory control at village trekking sites. So, welcome. Looking forward to seeing you.
Hi, I'm Tosin Seriki. First, I'm going to tell you a little bit about how our project is formulated. 5 of us went to Gambia, went to Africa this past summer. And out of the 5 of us, the 3 of us were able to develop a project. Initially, whenever we were going, we had been told that we were going to start EMR, electronic health records. That was what the CEO had requested from us. That's kind of the project that was kind of given to us on our destination. And after kind of really being involved in getting to the community and shadowing and going through our experiences in Gambia, we realized that EMR wasn't really useful at that moment, but we did notice a lot of other issues that were related to the dental health practices, as well as inventory control at trekking sites, which is basically off the hospital ground clinic. So they surround the village areas and they check different villages and they administer a lot of different wellness checks. So out of the 5 of us, we had 3 of us came with the project. And all the pictures that you'll see in our presentation are from our actual trip. This is at the actual hospital, right? So, yeah.
From one perspective of what the Gambia is, the Gambia is a small country inside of Senegal, located in West Africa. It's a very small country as far as land size, but its population is about 1.5 million people there. Poverty rates are pretty alarming. About half of the people that live in the country, half the population, live on less than what's equivalent to $1 a day here in the United States. The life expectancy is low. It's about 52 years old for average men and women. And here in America, it's about 72-ish. The literacy is high. The physician to population ratio is very low. It's less than 1 for every 10,000. Just to put that in perspective, here in America, it's over 25 for every 10,000. So they're very understaffed as far as physician ratio. They're plagued with preventable diseases, as well as a lot of sub-Saharan African countries, but they are one of the most progressive developing countries. So we'll highlight why that fact right there connects our project is actually going on in Gambia.
Alright, so kind of going off of what Idris said, one of the things that makes Gambia very unique is its cell phone use. On the rise internationally as a whole, in Africa as well as all over the globe, cell phone use is definitely an industry that is here to stay. Everyone has cell phones, as you can see in pictures. It's something that's very common. In Africa, the use has grown exponentially to over 65%, and then it's twice that of the actual global growth. So it's something that's just booming. Cell phones in the Gambia specifically are used in a variety of different ways. Used in households, used in marketplace, used in cyber cafes. There are just a lot of different ways for connecting to each other in rural and in urban areas. So it's something that's just really awesome to have. SMS is a way that cell phones are used to communicate non-verbally, and because of those high literacy rates, SMS technology is very unique, whereas we don't really need that much of a high literacy to really understand what kind of text or the messages within texting. So it's effective and it's affordable. It doesn't use airtime. The credit is sometimes free, sometimes it's not. It's not as expensive as actually costs. So it's very, very useful. Like I said, the use of information communication technology has shown really great promise, especially within the economy. It's really great with farming and marketing and understanding the supply levels. They're using it all different types of ways. So it's definitely something that we noticed when we were there, and something after we researched, we really found that cell-phone use is just this commodity that we need to utilize further into multifarious uses. So like the other two individuals stated, we stayed in Gambia for 6 weeks, and we worked at the General Hospital in Riyadh, Gambia. It's a very rural part of Gambia. It's a non-profit, full-functioning referral hospital, and it's also a teaching hospital with the organizing school. It was built by the Gambian government in 2003. They get some of their funding from the Gambian government. They also get their funding from other outside sources, partnering with schools like Junkung and other universities in the U.S. and abroad. They conduct weekly tracks in other 9 surrounding villages where they administer vaccinations for babies under 5 and pregnant mothers. They offer general vaccinations for mothers who aren't even pregnant, and they do baby well checks to make sure the kids are healthy, and they track their progress, and they do this once a week. And they offer a number of different departments and services, along with like the checking. They do cataract surgery clinic, they do baby registration, they offer maternal child health, emergency services, outpatient care, in the eye clinic and dental clinic, surgical wards, a lab, and minor and major theaters for surgery. So they do have a lot here. Obviously, the thing that's different from us here is they just have a lot of different resources that we have here. And the mission of the hospital is to create a fellowship environment, one in which care is focused on nurturing and healing the whole person while respecting each person's work and dignity. This is extremely important because the CEO of the hospital, Mr. Catheter, is really passionate about his hospital and how far they've come, and everything that he does in relation to the hospital is towards this mission and making sure that any individuals who come to help the hospital are working towards the mission. And we definitely are really very happy that we were allowed to participate.
So prior to the actual one. Based off of our research and our experiences in Gambia and understanding the vision of the CEO, Kevin Baji, we noticed two problems that we thought were the most important in trying to address it. And our problem statement was first to address the documentation there. While they're checking, like Tomi said, checking it when they go into rural communities and offer services, offer healthcare services for those that can't really make it to the hospital. So one of the things we realized is how they document the vaccinations is really updated. And what they do is basically have a really big book, and they tally and handwrite every vaccine that they give, every serving, every prescription or everything that they give. So we realized that sort of kind of has a bigger impact if we find a way to expedite that, and also if we develop a way to allow it to be easier to recognize or easier to analyze the data that they get from actually documenting those particular vaccines. The second thing we noticed is there are a lot of factors that attribute to a lot of poor dental health outcomes and other oral health outcomes. As Tomi mentioned, they do up there at the dental clinic, but the dental practitioners they don't necessarily go to the checking site. So unless you have a really tertiary need to as far as your teeth and oral health, then you really don't go into dental. You don't go to the hospital because it's such a long walk. Sometimes people walk entire days just to get to the hospital and then walk an entire day to get back. So one of our suggestions we'll get into addresses this need more specifically.
So I'm going to go a lot. We want to talk about three. These were the aims and objectives of our specific project. The first was to evaluate the efficacy, efficiency, and effectiveness of current SJGH health practices. We kind of talked about it a little bit, but just amongst us being there, we kind of were able to evaluate and understand how they conducted their health practices and get a better understanding of how we could help. Another one is to offer alternative options to deliver health and basic care. And a little further along, we'll talk about the recommendations that we came up with to address this issue. Develop a plan to integrate mobile technology with checking sites for vaccine inventory control. Because the CEO, one of his major goals was to actually ultimately implement EMR, we figured that using mHealth, which is mobile health technology, which is a huge initiative of Africa in general, was a great step in working towards that goal. And to improve the ways in which vaccine inventory data is used for analysis and research, which we'll talk about that a little bit later. And finally, to increase communication between health providers and patients, which is one of our ultimate goals. That's just a very futuristic goal. Overall, we want just to really bridge the gap between patients and physicians and really create a very open environment for a dialogue and understanding of medical issues. So obviously, we definitely want to make sure that anything that we do adds value to the community. We want to make sure that we're working towards their goals and we're meeting at the same place. And we believe that our project definitely is in line with the Ministry of Health goals, which they are interested in improving the efficiency and effectiveness of healthcare delivery in the Gambia overall. And as we mentioned before, the CEO of the hospital has huge initiatives for electronic health records and just mobile and electronic health implementation in general. So we feel that we've respected that wish of his as well. And we think we've identified a lot of major operational and administrative challenges that this hospital specifically encounters, and we hope that our recommendations will help alleviate some of that stress and make things a little bit easier for the staff and the patients to come to the hospital.
So our research design and methodology, just to let you know, we didn't just wake up and decide to just tackle this issue the way we wanted to. We did a lot of literature reviews. We really perused a lot of data talking about mobile technology in indigenous communities in developing countries. We met with a lot of people while we were there in our almost 2 months in Gambia. We didn't just come up and say, you as a dental worker, this is what will make your job a lot easier. You as a public health practitioner, this will make your job easier. We were asking them what were some positives and negatives about what happened. Like, what would they like to see implemented? And I'm not sure if you guys are familiar with the system in certain parts of Africa, but it's like this dictatorship type leadership practice over there. So although somebody may not like a certain thing, because just the respect level of the culture over there, they may not say anything to the CEO as far as their workload being too much, too overwhelming. So these opportunities for us to connect to these workers gave them a sense of empowerment to let them know they sort of kind of control their stress levels, and they control basically what they do as they work. So we talked to a lot of people. We could go down the list, but it'll bore you. So we talked to a lot of people in the Gambia, and also when we came back, once we realized the way we wanted to attack this problem or intervention, we talked to so many people around. We found there are a lot of people in Philadelphia, and not just at drug school, but also the University of Pennsylvania, that are doing so much work abroad, specifically in West Africa. We found some people that work in Mozambique. Namely, we connected with Dr. John Holmes from the University of Pennsylvania School of Medicine, and he's into medical informatics. We talked to Dr. Seriki, who's she's really into multivariate analysis in developing countries. We talked to a host of other people. Power of Gambia is an initiative that we saw, which is it developed from the University of Pennsylvania, but now drug schools are really helping it. They implement a lot of solar panels. They also implemented something called a solar suitcase, which I don't know if you guys have the question of, but we're trying to implement technology in a country where a lot of things aren't as stable as they are here, such as power. Fortunately, Power of Gambia helped the solar suitcase idea, where you basically have solar panels in a suitcase and charging stations. Those mobile charging stations where you use the sun as the main source of energy. So we found that out, which again further helped us push for our idea. We did observations. We don't have it here, but we got plenty of pictures of us being in the field and actually doing the documentation, helping with the trekking services, as well as note-taking and journaling. Some were very emotional because there were a lot of highs and lows in the Gambia, but we did a lot of journaling. But when we came back, we used this toolkit, the Human-Centered Design Toolkit, to make sure everything that we had, all of our solutions, all of our interventions, weren't necessarily what we think, but really is human-centered, is really going to change the habit and improve the habit of the human, the people that are actually doing these jobs. So that allowed us to brainstorm, question storm, as you see on the side, like we said, our pictures are our pictures. So we did a lot of process maps, we did storyboards. So as we came up with an idea, we put that idea into what we noticed during the training experience, and saw if and we actually timed it sometimes to actually see if it cut down on time, because a lot of people like to talk about the efficiency word, but if it doesn't cut down on time, it isn't really more efficient. So we actually put our ideas into action, and we use this really cool data analysis software in vivo. And it's a qualitative data analysis software. We can put pictures, videos, thoughts, everything. You can just put it into this database where it actually analyzes and it codes so that you can find common trends, like word files. Again, we use it as a tool to make sure our intervention matched the actual need, and we weren't just going with what we thought felt best. So, again, that's just the picture. That's what.
Okay, so we're talking a lot. So here are the recommendations that we came up with. We have 5. So because our project has 2 components, which is the vaccine inventory component as well as the dental component, we have 5 total that kind of comprise the book. So the first 4 are towards the vaccine inventory. So, like Idris stated, because they use a handwritten system, our first recommendation was to be able to use a weight tablet application. So the tablet application is the same thing like an iPad you see here, where the public health worker would have this physical iPad, and then the exact same document that's written down would just be uploaded on the iPad. So it doesn't really change the actual regular momentum of how they report things. It really just puts it on technology. They can physically put it in the tablet, and then it'll upload, and they can have it stored. You have the intelligent scanner recommendation, which is kind of like the scanner down here, where each vaccine will have a barcode, and you'll be able to scan the barcode. That way, it'll save it on the actual scanner, and they can upload it, so you can actually have a digital copy of what's being used at what rate and where. Then we have a computer scanner option, which is the exact same way we use our computer scanner here, but they would still use the blue book, but then they would be able to upload, they would scan the blue book and upload to an Excel document on the computer, and then they could then log in that information on the Excel computer so it would be organized and be easily researchable. And then we had a non-tech option, just because we realized that technology isn't always the best option. It seems like it here in America. It seems like, of course, these technologies are sometimes not always easier. So we had just to reformat the current documentation books using tabs. Right now, it's very, very difficult. The books are huge. They put them in a room where they collect stuff. So you can't really go back and look at things. So we decided, what if they just had tabs that divided by the villages, per month and per week, so that you know that when you go to this village this week, you use this tab, and they can go back and know which tab to coordinate with which village at what time they went there. So those are the vaccine inventory control recommendations that we came up with. And then for our dental intervention, I guess our first recommendation was to use dental at the checking site, because this is currently happening right now. To bring a dental clinician there along with them to be able to check on these women and children who are currently there already. And so, using this, they would check the patients, and if the patients were too severe, if they would have like an abscess, or just something that after checking site they couldn't actually fix at that moment, they would use the text messaging. The clinician would text message the patient to come to the hospital the next day, so they would have a dialogue with each other in order to kind of have a communication, so they know, okay, so I can't treat you here, but come to the hospital tomorrow, and they'll have a reminder kind of following up, reminding them, and then once they get to the hospital and they're actually treated, the actual dentist will text the patient a follow-up saying, hey, don't forget to gargle, or don't forget to chew on your chewing stick, or something. It's just a reminder, because a lot of times now they're not reminded. So when they leave the dental clinic, they just go about their business. Nobody ever really kind of keeps in touch with them and lets them know what's going on, or that they should come back, or things like that. So we went to a workshop, and we were able to play with this frontline SMS software that allowed us to actually send out auto replies and auto text messages, and then receive text messages, and categorize actual patients. So you can categorize if people are severe. You can have a group of people who are like, oh, you send a text message, and those are the people that get the message to come the next day. So it's a really cool software that we got to play with, and we're actually pretty excited about it.
Okay, so I guess in general, you may not know that the community-based matching projects in the past have always been done individually, and this year our concentration in health management policy has broadened. I think they did most. They broadened it to where individuals were allowed to work with partners or in small groups. So they're still trying to figure out how this works and how well the dynamics will be. So in general, as you can imagine, there's been some challenges for us, just coordinating work time and coordinating time to meet with people between the three of us. Because you can imagine coordinating three graduate student schedules is a bit stressful along with professors. We've had some problems getting in communication with the CEO of the hospital since we left because of the time difference, and when he's available, lacking network connectivity on his side, so it's quite difficult. And as you can imagine, none of us are technically savvy, I guess. And so we had some problems in the beginning because we didn't really know too much about software development, but we've done a pretty good job working our way as the project has progressed and learning a lot more about it. And like I said, we've been able to go to workshops and stuff and educate ourselves a little bit more. And also cultural competency. Sometimes when we're talking about our project to individuals who aren't very familiar with medical health abroad, let alone in Africa specifically, it's really difficult to kind of get them on the same page with us. So just kind of like being able to explain things to individuals who obviously weren't there with us and have first-hand experience. We believe it's very important. We want everyone to understand exactly where we're coming from. And some of our other fellow students are actually, who are working with us now, go to their sites every so often. And unfortunately for us, we went almost a year ago now, and so we haven't been back. So it would be great to be able to go back, but unfortunately for us, that wasn't an option. But that's kind of been a little bit of a challenge, but it's pretty much good.
All right. Moving forward, besides all the information we gave you guys today, we have, actually this PowerPoint slide is a little old, about a couple weeks ago. We have made a lot more advances in certain options opposed to others. We actually present our final we defend our final thesis next week, so it's a little spill. If you guys want to come and check it out, the 15th at 9 o'clock, you'll see the finished product. Yeah, but besides that, again, we've actually been very fortunate to be featured, like Tosin talked about Frontline SMS, when we went to the conference, just with a bunch of other professionals that were there trying to learn it, they said we were the best organized and best presented group that they've seen since they actually had the conference, and they offered to feature us on the website. So our blog will be on their website. We also were asked to be featured on the School of Public Health's website from all the work we've done. also not patting ourselves too hard on the back, but the work that we've done actually it paved the way for what is now the Objective Public Health Global Initiative Certificate. So it's now, from our experience of 5 of us sitting at a coffee table, actually out there in the lobby before class, and that conversation is now a certificate you can get from Drexel. So it is a sustained program as far as our experience in Gambia, but our project actually has been picking up a lot of steam from outside agencies that want to take it on even after we graduate, even if we don't want to take it on, which we actually do. So outside of that, like I said, we've researched more and we have a lot more data, but that's all we're going to give you on today. That's it. If you have any questions, feel free to ask. Thank you again.
We're going to move along quick because we're running tight on time, but I've got a lot of questions for you folks when we're done. Our final speaker, Amy Glassifer, is a doctoral candidate in nursing practice. Amy graduated from the University of Pennsylvania with a BSN in 2000 and her MSN in 2003, and she's worked in nursing education since 2005. For the last 6 years, Amy worked as a unit-based educator at Virtua Marlton, and in this role found her passion for promoting evidence-based practice at the bedside. I just want to comment quickly. Those of you who follow what has been in the news with the Affordable Care Act, there is an enormous increase in emphasis on basing hospital care on scientific evidence to reduce infection rates, to reduce readmission rates. So this ties in directly to what you're seeing in the news all the time right now. So her topic is the effect of a clinical decision support system utilizing a business process management-enabled workflow on the adoption of a protocol for nurse-directed urinary catheter removal. Amy?
So that's a mouthful. And I've been working on this, I think 9 months now. I've been in the process of working on my proposal, and I go to just on my proposal on May 24th. So, yeah, we're getting there, right? So, my goal really for this presentation is by the end you can look at that and be like, all right, I see why that matters. Here are some statistics I'll let you read yourself. But really what this shows, as you were just saying, really disturbing. Going to a hospital is an unsafe thing to do. And as a nurse, or really any clinician, knowing that when you surrender yourself or you surrender your loved one to the healthcare system, that we may actually do more harm to you than good, is very upsetting for people who entered into what they thought would be like a caring profession, healing profession. So the AIDS leading cause of death, that means that perhaps you're coming to the hospital for something that isn't even as lethal as being in the hospital. So we need to make some strides. And this data you can see is from 1999, but the IOM continues to follow this, and we really haven't gotten any better. There are a lot of ways that we need to make people safer in the healthcare system, and one of them, like you said, is by making sure that the care we provide is based on evidence. So this, the IOM says that this is a priority. By the year 2020, 90% of clinical decisions need to be based on evidence. And the data that I could find said that we're in acute care, which is my world, is that about 70% of acute care decisions are based on evidence. And this is as opposed to like status quo, because it's the way we've always done it, because it seems to work. So here I am 6 years ago as a unit-based educator, and my assumption is that everybody who comes to work, they want to do what's right. They just don't always know what it is. So as an educator, I have an opportunity, really in a hospital, at the point of care, to change things. So here's me. I am so excited I got this, and I'm going to do posters and in services, and I'm going to make a big difference. And it really didn't take long until I felt more like this. You know, Sisyphus, right, rolling that rock up, the same boulder up the mountain every day, only for it to roll back down. We're really not getting anywhere. Things aren't changing, behaviors aren't changing, outcomes aren't changing. And I'm thinking, what is the matter with these people? Why aren't they doing what I told them? So then I reflected back. And this is when I was entering into my doctoral work, and I reflected back initially I wanted to think about like what makes a nurse a good nurse. Some people really do what they're supposed to do, but others don't. But as I thought about it and read more, I realized everybody does want to come to work and do a good job. Right? The problem is that clinicians work tirelessly to care for the patients in an increasingly complex, inefficient, and stressful environment. So hopefully you guys have not spent much time in hospitals, have not really had to observe the work of a nurse, but it is chaotic. And it's since the 6 years ago when I last had a patient assignment, it has changed. And I wouldn't be able to do today what I was able to do 6 years ago. So as a result of this, we do fall short on our potential to provide quality care. So we need some new strategies. The same things and trying them over and over again is not going to make a difference. So we need some new strategies. Fortunately, the government is agreeing with me. And they have put a lot of money into looking at can technology help to support evidence-based practice. So there's this High-Tech Act, which has allocated $22.6 billion in funding corporation of information decision support systems into healthcare settings. So that means at the point of care, a physician, a nurse, a therapist has to decide something very basic, like is this the right medication for this patient? A clinical decision support system could pop up and say, hey, this patient has an allergy, don't give them this medication. And that would be a way to protect the patient from a preventable adverse event. So now here's me. I'm thinking, I could be the world's greatest educator if I have all of my old tools plus this clinical decision support system. But really, I'm interested in teaching outcomes. It would make me look good. So specifically, the example that I'm studying are catheter-associated urinary tract infections, or urinary catheter-associated tract infections. So just I'm not sure where everybody is. I don't want to make any assumptions, but a urinary catheter is a tube that goes into the bladder and connects to a drainage bag. It's left in to collect urine. Okay. The bladder is sterile, so any bacteria, now we have this way, this vector for bacteria to travel into the bladder and cause an infection. It is the most common hospital-acquired infection. It's not the most deadly, but it is the most common. And it does result in about 13,000 preventable deaths a year with an associated cost burden of $460 million. So it's a significant problem for us. And it's preventable. I mean, that's the real thing. We don't do stuff that shouldn't have to happen. The single most effective way to prevent it, once you do have a catheter in, is to get the catheter out as soon as you don't need it. There are medical indications to have a catheter. But as soon as that indication is come, we need to get that catheter out. Unfortunately, we are not very good at doing that. And this is, even on the low side of this estimate, I see as high as 50% of urinary catheters are left in unnecessarily. So even though the evidence says get it out, we are not going to. I know this is really small, but we don't need to know what to sell. The point is, one of the reasons why we're not very good at getting catheters out is it would require a physician order to remove it. Physicians don't actually know which of their patients have catheters in. So if you're waiting for a physician to write an order when they don't recognize that the patient has a catheter, that's a main issue in why they get left in. And then it's like the day of discharge, and we're like, oh, yeah, you don't want to go home with that. Let's get that catheter out. So at our hospital, in January of 2012, this is one of the evidence-based prevention methods, is to have a nurse-directed protocol. So at our hospital, we have this. In that blue box are all these reasons why a catheter would have to be remain in. If your patient does not have any of those criteria, the nurse is empowered to go ahead and remove that catheter without a physician order. If they do have any of those indications, then the nurse does have to consult with the physician and say, do you still want me to maintain the catheter? This went into place in January. We rolled this out with all the regular posters, staff meetings, one-on-one education. And then in May, we implemented this clinical decision support system utilizing a business process management enabled workflow. What does that mean? It's really kind of like GPS. So a patient is admitted, they have a urinary catheter insert. In the electronic medical record, it's listening. It's listening for that a catheter has been inserted. Now it knows. Anywhere a nurse documents that a catheter has been inserted, it knows in 2 days I'm going to remind that nurse to get that catheter out. So 2 days after the catheter is inserted, the nurse gets this alert on her screen. Says, hey, it's been 2 days. Do you want to discontinue it or do you want to continue it? And if you're not sure, I'll link you directly to that protocol that you guys were looking at. So the nurse then can select either discontinue or continue. And the order will pop up. I know you can't probably really see, but that the order is this is yours in the way. This one says to remove the urinary catheter, and this one says to maintain it. And then the nurse will hopefully act on whichever order he or she makes. So, these are my specific aims. What is the effect of the business process management enabled workflow on nurse-directed catheter removal and the associated outcomes? So specifically, I'll be looking at were catheters removed because the nurse made that decision, or were catheters did we still sit and wait for a physician to come by and write that order? Because there's nothing to stop a nurse from ignoring that alert. She doesn't have to act on it. She could just turn to her blinder and keep on going about her day. And then it's to look at, did we actually impact any outcomes? So the outcomes that I'm looking at are our CAUTI rates, so the catheter-associated urinary tract infection rates, and also our urinary catheter utilization. We every day collect information on how many urinary catheters do we have in our house that day. So hopefully, if we're getting them out sooner, that number should go down, as should our urinary tract infection rates. I'm also interested in finding out, if not why not. So we'll be looking at some patient factors to identify the patients most at risk for not having their catheter removed based on the nurse-driven protocol. My theory is that a patient who the nurse thinks may be incontinent upon removing the catheter, the nurse may be less likely to remove that catheter, not because the nurse is lazy and doesn't want to take care of that patient, but patients who are incontinent, if it's the specific risk factors that I'm looking at are age, gender, mobility, and pattern of status. So if I see an older woman who's confused and not safe to walk by herself, if I think about removing her catheter, I'm worried that maybe she's going to get confused and hop up and fall. So I'm worried about her safety. But really, those are not indications to maintain a catheter. There are other things that we need to do to keep her safe, but also have a catheter out. That's my theory. We'll see if it's true or not. And then to explore the experience of nurses interacting with the workflow, just to see what do they think of it, do they like it, do they hate it, and also the nurse-directed urinary catheter removal protocol, because in the work that's been done around that so far, the literature has said that nurses don't feel empowered to do this. They feel like they really need to still have this discussion with the physician. They're not taking ownership of this practice. So aside from being the greatest educator, I really want to see if clinical decision support systems are a viable option to help bridge the gap between evidence and practice.
Thank you, Amy. That actually gave me some good examples to use when we're teaching evidence-based practice searching to the nursing students. So I know we're
dwindling.
We're dwindling and we're over on time, but part of the purpose of this program is conversation. Yeah, talking about what you're doing, so if everybody has a little bit more time to spend, if we have some questions. I have to say, I was really fascinated in what you guys are doing, because I had the opportunity a couple of years ago to work on a research project with faculty from the iSchool that involved using text messaging with clients of the 11th Street Health Center who were in a pregnancy support group. And what we really did was put together a library of, just little health reminders for pregnant women that were sent to the participants in this group. So, seeing Dr. No, it was Brittany Dalrymple, Michelle Rogers. I can find his papers that were written up about it, so if you're interested. But things tie together. It's really interesting how, these things carry across. So, questions? Any comments on?
Do you guys have questions for each other? I mean, I was yeah, very different.
I know we've just finale, but
So I have a question for everyone. How did you decide that this is what you wanted to do? I mean, some of you touched on it a little bit, your background and why you wanted to be involved, but like earning your PhD is tough. I mean, especially with children. What made you really want to get into that? I mean, what was the core of your decision to get into your research?
Well, mine is that I started in 2005, which is a little scary. I know that's a long time ago. And at that time I was newly married to a resident, and he was never home.
Right.
Yeah,
no, that makes sense.
But I decided, and then I had my daughter, and then I didn't stop for 5 years, and then I had my son, and now they're. And I was like, oh my gosh, I'm going to run out of time. And I felt our work I did.
Sure.
Wow.
Brett, sorry, the question, do you think that would benefit the time that you took off to like fortify your passion in it?
Yeah, actually, my dissertation question when I left, because I was almost done, I only had 2 pages left, it's not at all related to what I am working on. So, yeah, absolutely. Ours was just like I just kind of mentioned, we were in class one day, and we were like, we're talking about like opportunities, and we were kind of like, why not all go out abroad? We didn't know what we wanted to do. We first started was just like, oh, we're going to Nigeria. We were from Nigeria, we're like, oh yeah, we did, we set it up, it's good. And then Dr. Marquez, which is the global health coordinator. Yeah, she had a project, which is the one that the CEO had told us. She already had that established. She's like, well, if you guys want to do this, this is like a great project for you guys. And so we were like, cool.
Yeah, like Tosin said in the presentation, we went there, we was as graduate students, like, we're going to implement electronic medical work in Africa. Like, that sounds awesome. A lot of American hospitals give us pushback, but we're going to Africa to really do this. When we went there, actually we jokingly talked about it for 5 months. That was the greatest thing about having a group dynamic. That's what we wanted to continue with our group our group master's thesis, because you get all these other perspectives that only maybe you don't get on the defense, but you get we're getting year round. Like if we get an idea presented, we would bring it, and we had like brainstorming sessions. There wasn't much to do anyway, so we had brainstorming sessions. But at EMR, once we went there, of course we wanted to take the world into EMR, but we realized, let's apply all these concepts that we learned in class that we didn't think we knew. But let's apply them, like, let's take a step back and scale back just a little bit. You want to do this big project, and this is how we thought before the CEO. Like, you want to do this big project, but it's smaller, more minute issues that if we focus on those once the EMR is finally implemented, it'll be a lot more sustainable. So that, again, throughout the course of just trying to see what's the most feasible, viable, and realistic, honestly, that's how we came to our ultimate project, which, like you said, the slide was about a week or two old, and within that 2-week time, our project then made another smaller change to make it more realistic and easier to sell.
Honestly, like you're saying, it's changed so much from the first, right?
Yeah.
Even this past 2 weeks, we're like, okay, now we're doing dental. Like, because we just kind of like, after really like talking, like, there's other problems that we can address. So, like, it's definitely something that we kind of all
spirals, Sure, I guess you know.
So we were the first cohort of health students before us, and there was no like pre-study global health program before. So it's really like we want to go because we don't have money for you. And then Dr. Marquez kind of funneled our ticket costs, and we got our tickets covered. So the 5 of us, like, we had a blog. We had a group. We called ourselves Love Abroad. We used outreach to volunteer endeavors. We reached out to family, friends, like this PayPal account.
Wow.
We got a Twitter, Instagram, we just lots of people, and we really raised, like, we didn't come out of pocket for any of it.
Oh my God.
Yeah.
That's crazy.
We already come out of pocket.
No,
We can't raise it, we're not going.
Fantastic.
We got a lot of support from people that was going in Idris, so it was even more rewarding, and then to see it where it's coming now, almost a full year later, it's absolutely crazy. So that's very exciting.
Idris, what you said about, defining the scope of your project, one of the speakers at the last Books and Bagel said something about one of the hardest things for her in really defining her dissertation was realizing that this was not going to be the scope of research that she was going to do for the rest of her life. That this was going to be one project, one piece. And I actually ended up sharing that. We're doing a series of workshops with teaching faculty in the College of Nursing and Health Profession who want to get more into doing research. And we ended up talking about how, you know, you see this project or this problem or this idea and it's so big. And accepting the fact that, okay, I can do this piece of it. This is what's practical, this is what's workable.
That's you.
Yeah. Figure out what the piece is that you can choose.
Before we go too far off, I want to get to your answer.
I used to work in adult psychiatry. That was one of the things that, and I worked in adult psychiatry for like 12 years. And then when I really wanted a different work-life balance, I started working together with children and families. A lot of the skills that I had really came to bear when working with families, particularly families who were experiencing some stressful trauma. And I wanted to understand. I knew how to work with the adults, it was great. I didn't know how to do it. What do I do with the kids? You know, and it's not really working with the kids. I can work with the kids, but how do you make the jump to helping the parents feel like they can be with the kids?
Yeah.
So it was really that experience, and then also we had some minor chronic moderately difficult issues with my children. When they were young, that stressed us out, and needing to kind of work through what it is that I need to do to allay my own sense of empowerment and know that they didn't lead as a parent.
Mm-hmm.
And so how does all this sort of do together? And really, it's also evidence-based driven because I have the sense that these therapists are reinventing the wheel every time they walk into a clinic.
Yeah.
Into a clinical setting, and I hate that.
Mm-hmm.
It keeps us tired all the time. We don't have a clue about how to make our work sustainable, how to train others to do this work. So, wanting to be able to get into a profession in that way.
Wow.
Question for you. So I'm a full believer about music therapy. I think that is great. But what if you can't sing or not musically trained out? Our children do.
No.
You have a wonderful voice, and I was like, I can not. Your kids will never
over and over and over again. It's really but if you were no, because your child is already hearing your voice from about 15, 16, 17, 18 locations. Mm-hmm. Your voice is the one thing that is the most comforting. So one of the things that I know that the literature knows is that mothers of infants who were born preterm and have to spend time in the hospital did better on physiological outcomes related to stress and feeding and oxygenation levels when they had CDs of their mothers singing lullabies as opposed to children who didn't have those CDs. They only did, and they compared healthy infants as well to that. So it doesn't matter who's in my voice.
Wow.
You had a question back there.
I have a question for the in terms of, I'm not going to the process, you all have to go but if you have recommendations where there are those being implemented or
so the overall goal of our project, I guess you could say based on, is to just present this plan to the CEO of the hospital with the hopes that part of it or all of it will be implemented. Obviously, we're graduating in 5 weeks, and we're hoping that
another, and incoming, another a current first year can take this on as their CBO for next year and work on the actual implementation of the project. So because of the local health certificate program, they actually have 12 students going to Gambia this summer, and so if the student plans it right and they do want to take this on as their CBO, they could potentially go to Gambia for spring break or during a summer. So we're hoping that it definitely moves further, way beyond where we're going to kind of keep it and push it on. So that's the plan. So we're hoping that the CEO is 100% on board with some or all of it at least. So thank you for doing that.
And one second, how much do you guys think about local resources in terms of, so maybe think of this in terms of experts or academics that can make this sustainable in their own community and not for them have to rely on, funding from grants from the U.S. and things like that. Where does that come in? Projects like this.
Actually, with our project, we really wanted to take a realistic perspective and approach to this project. But one of the, in meeting with the hospital CEO weekly, and sometimes more than once a week, we realized that he's really focused on technology. He's really focused on outside grant money. He's really focused on American money. He's really focused on that. And we realized for us to meet what we want to do, meet our outcome, we sort of we have to play along with it. So we have to think of technology because that's what he really wants to implement next. So we figure if we play along with what he likes, and we play along with the community needs, that's the best way, and that's the best approach to try to get a problem going. So we definitely were understanding that we should be more resourceful to what you guys already have. But even a lot of our suggestions, even when we were there, they sort of got pushed back when it didn't line up with what the CEO thought of technology, money, more stuff into the country.
But as far as sustainability and funding, something that we noticed also is because really how we self-include everybody kind of already has it, it really is no use for funding there. But for the SMS system, it really is just training. So we've actually trying to work on designing a modem to send in there so they don't have to worry about that actual extra expense. All you have to really do is train. We actually know people who we want to fit in there. We know we want the DACA, the clinician to go, to the training stuff. So we have the people we have in place to actually train. And then once we train them, it's all through that inside us. You know what I mean? So there really isn't any real new funding except for the money for text messaging. A challenge that we're kind of having right now is getting people that actually want to send their text messaging to spend their own money to send, the follow-up text. We're kind of trying to tackle that, but there aren't that many funding, things that we've really had to encounter so far. In fact, just training and making sure there's actual understandable, understanding about how to use the system. Thank you for something. Yeah. Okay. Oh, sorry. Okay.
We're running out of time. Before you guys go, though, I do have gift bags for all of our speakers and our moderator from CSA. I do also have certificates. Thank you. So yeah, grab a bag. Awesome. Thank you so much. Yeah, no, thank you guys. Yes, no. And I would really love to compare notes with you from our project to yours. That's why you're doing this. I didn't see it on the No, it's definitely covered. Sorry about that. All right, everyone. Actually, thank you so much. One of our better moderators. Thank you. Thank you. Great. And very good. Thank you. Yeah, it's still, regardless, it's still a great time this year. I personally do them, and I feel they're all different. Yeah. I really wonder how some of the ones on the other side. Yeah, we do have a huge challenge. It's been happening there kind of very often. Still more. So, we're trying to see how it's going to go. Better space is right, yeah.
Yeah.
And I know he has the space available to just kind of overshoot it. But yeah, it's just space. Thanks, guys. Have a good day. At the classroom. Yeah, I mean, we're having a meeting tomorrow to just discuss how everything is going with Books and Bagels. So I can mention it.
I mean, the classroom we have in the library, it's a small contract for that's absolutely horrendous because it's